The last part of this video lecture discusses the follow-up of patients. We actually will answer two questions, and the first one is the outcome different from the previous one? And the second one is the outcome below or above a consensus treatment goal, which may be more clinically important? To answer the first question, whether an outcome is different from the previous one, we need variation information, and this means analytical and biological variation. We return to Christine Franzen. Because of her cystic fibrosis, she has an increased risk to develop diabetes mellitus, and therefore the measurement of plasma glucose is performed 3 monthly. In this slide we see the glucose concentrations in plasma from February 2014 up to January 2016. The glucose has a steep increase from 5.4 millimoles per liter up to 7.3 millimoles per liter. Still no diabetes, but the trend is obvious. But are those values significantly different from each other? The reference change value is the mathematical difference in percentage between the baseline level and the level after therapy initiation that represents an actual difference at the desired level of confidence. And in statistics mostly we use 95% confidence. We can apply this concept also between consecutive levels of glucose, as in the case of Christine Franzen. The reference change value is also known as the least significant change or critical difference. We use a complex formula to calculate the reference change value, but when we just simplify it, we need to know the total variation, which is the mean of the intra-individual variation and the inter-assay variation, to calculate the total difference. Simplified, and you should remember this formula, it is 2.77 times the total variation when we apply just one measurement before and after. And this is what we most times do in clinical chemistry. So please record 2.77 times the total variation, which is the sum of intra-individual variation and inter-assay variation. Reference change values of many clinical chemistry parameters are well known, and for glucose the reference change value amounts to 14%. If we apply the reference change value to the glucose levels of Christine, we see that each consecutive measurement is not significantly different from the previous one. The highest change is 7.8%. However, this is far below the 14% that is necessary to be a significant change. However, when we look at the difference between February 2014 and January 2016, we see a difference of 35.2%. In other words, no significant consecutive change, but a significant trend. It should therefore be noted that although two consecutive measurements may not be different from each other, the trend may be. To come back to reference change values, they differ quite a lot. For example, serum sodium has a very low reference change value, which is not surprisingly because the mean intra-individual variation is very low. On the other hand, we see very high reference change values, for example for creatinine kinase, which is very variable within an individual, with an intra-individual variation of 42%. Also, plasma cholesterol and triglycerides have pretty high reference change values due to their high intra-individual variation. Please consider that there's only one measurement in clinical chemistry most times, before and after treatment initiation. And we don't know exactly what the variation on this analyte is. Is this a real difference? We don't know. Maybe this was the curve of all values that appeared in this patient, but we only measured this and this. And there may be a difference, but we still don't know. We see that there is huge variation. But is this a difference? There seems quite consistent values of this analyte. But is it difference? Again, for this we need the sum of analytical and biological variation to determine it. The last question to answer is whether the outcome is below or above a consensus treatment goal, and for this we use glycosylated hemoglobin, which is used as a parameter in diabetes follow-up. The American Diabetes Association advises a treatment goal for glycemic control of 7%. This is based on hard endpoints, which is shown in the next slide. The treatment goal of glycemic control in diabetes is derived from the Diabetes Control and Complications trial. On the left panel, we see the rate of progression of retinopathy as a function of the glycosylated hemoglobin. We see an increase of the risk of retinopathy with increasing glycosylated hemoglobin. However, it seems that the risk does not decrease steeply anymore at glycosylated hemoglobin levels below 7%. On the other hand, at levels above 7%, there is a steep increase of the risk of retinopathy as one of the complications of diabetes. It should be noted that strict regulation of glucose leads to an increased risk of severe hypoglycemia. And this means that there's also a relationship between glycosylated hemoglobin levels and the risk of hypoglycemia, with the highest levels at glycosylated hemoglobin levels, with the highest risk of glycosylated hemoglobin levels below 7.0 and the lowest levels above 7.0. So there's a balance between the risks at a level of 7.0. A few years later, the survival of patients as a function of the hemoglobin that was glycosylated in subjects with type 2 diabetes was investigated in a retrospective cohort study. In both insulin-based regimens and metformin plus sulfonylurea based regimens, we see that there's an optimum of hemoglobin, of glycosylated hemoglobin. This means that it's no good to strive for the lowest hemoglobin levels. The optimum lies between 7 and 7.5 in the oral diabetics and a bit higher in the insulin-based regimens. The conclusion was that both low and high mean glycosylated hemoglobin levels were associated with increased all-cause mortality and cardiac events. Thus, it was stated that diabetes guidelines may need revision to include a minimum hemoglobin AC level. So actually the American Diabetes Association nowadays recommends indeed a cutoff value of 7%, but more stringent treatment when people are newly diagnosed, with long life expectancy, with absence of important comorbidities, absence of established vascular complications, and when patients are highly motivated and have excellent self-care capacities. On the other hand, Treatment can be less stringent when there is a high risk of hypoglycemia, when the subjects have long-standing diabetes duration, short life expectancy, etc. So hopefully after this video lecture and after the morning of instruction, you are able to understand the role of clinical chemistry in diagnosis and follow-up of patients, describe the sources of variation in clinical chemistry, answer the question whether a test outcome is normal or abnormal, making use of reference values and cutoff values, and taking into account sources of variation. You understand and describe the establishment of reference values and cutoff values, including their disadvantages and advantages. And you can use the Bayes theorem in diagnostic accuracy and calculate and understand and interpret the parameters of diagnostic accuracy. And also you can describe and use the factors that influence the interpretation of lab results in the follow-up of patients.